Getting healthcare right is, or at least should be, a tag team affair. But that tag team between researchers on the one hand, producing evidence, and policymakers actually implementing policy and care often doesn't work very well. What we're going to talk to you this morning about is a program that we have worked out between the Center for Applied Health Research, that I'm the director of, and the leaders of the healthcare system, represented this morning by Kelli. We're going to talk to you about a program that we've worked out that attempts to make this tag team work, or to build a series of bridges between the researchers and the users of research, between the people who figure out what works and what doesn't, and the people who have to make things work. So it's about a program called CHRSP, which is the Contextualized Health Research Synthesis Program, and we'll describe that in some detail. From the point of view of a health researcher, or the kind of health research unit that I'm involved with, one of the key challenges is getting the evidence to the decision makers and the clinicians. How do we get scientific evidence used more frequently and more effectively by the healthcare system? So that's the tag team challenge from my perspective. Kelli will now tell you what it is from her perspective.
As a health system leader, it certainly is our goal to have evidence-informed decision making. But the reality is that the scientific evidence is only one of many competing inputs into our decision making. Our key challenge is how to locate and use research-based evidence to make decisions within our realities, so within our social, geographical, economical, and political contexts. One innovative approach to it has been the CHRSP program that Stephen spoke to. It is an inclusive process that involves the 4 health authorities, the Department of Health and Community Services, and their Center of Applied Health Research. We work together to support evidence-informed decision-making in health. It provides the best and most appropriate evidence quickly within limited resources. So certainly the 4 health authorities are involved, and the process is that we're involved right from the get-go. We help identify and prioritize the question. We participate certainly as co-investigators on the project team, and we provide context advisory role, as well as an important dissemination role. It truly is a collaborative process involving researchers and research users. And for us, this really ensures that the topic is relevant, timely, and a priority for us as health leaders. So today I have certainly the privilege of being present and representing the 4 health authorities and representing Western Health. Western Health certainly strongly values the CHRSP program and the work that we do with the Center for Applied Health Research.
Let me say a few words about the Center for Applied Health Research, because I forgot to put that slide in. We've existed since 1999. We were established by the university, by the healthcare system, to bridge that gap, to do research, to encourage research, to help fund research, and above all, to work with the leaders of the healthcare system to get evidence into practice. We tried a number of techniques for doing that tag team. We tried seminars, we tried training programs, we tried having research projects sponsored on topics that were picked by the health system leaders. None of that worked very well until we came up with this new solution, which we call CHRSP. The approach has a number of features which I'll spell out initially, then we'll go through the process and describe it to you, and then Kelli will sum up the key features again. So rather than doing broad interaction with the healthcare system, we focus on specific questions. And we use questions not that we think are important, but questions that are identified by the 5 key system leaders, that is the CEOs of the 4 health regions and the Deputy Minister of Health. We then use expertise at the Center for Applied Health Research, which for the next 3/4 of an hour will be called the Center. We use our expertise, both internal and contracted out to formulate each of the issues that's identified by the system leaders as a researchable question. We then go out and look at the scientific literature on that question, but we try to look not at individual primary research studies, but at what we call systematic reviews. That is, studies that take a number of primary studies and examine them carefully to see what they agree on, what they disagree on, and what the quality of the evidence and the findings is. We then shape both the questions we ask and, above all, the findings of our synthesis so that they fit the local context. There's no point describing a problem or describing a way to solve a problem that would work in New York State or in New York City, but that doesn't have a chance of working in this specific context of Newfoundland and Labrador. So we focus on the solutions that are likely to work here. And then we report to the system leaders and then to the general public via our website and dissemination processes on the results as quickly as possible and in formats that can be used by the system leaders. How does CHRSP work? As we've told you already, it's a partnership. It's the Center for Applied Health Research and then the 5 system organizations as partners. There are 7 steps in our process. In fact, at one point, we had this described as 14 steps, but it's much easier if we collapse some of them because otherwise the presentation would take all day. So there are 7 steps. The first one is that we work with our 5 stakeholders, the 5 organizations, to identify issues that are important to them, not important to us. I have a list of priorities that I would like to find out about. That doesn't matter. I'll do that on my own time. On their time and on their dime, it's a lot of dimes actually, we want to answer questions that are important to them. And we deal with the 5 top leaders plus what we call CHRSP Champions. That is a level within each of the 5 organizations that Kelli is going to describe to you in a minute. And we use a series of filtering criteria to differentiate the questions that we want to answer from the questions that either we can't answer or we'll answer later.
The CHRSP Champions are decision makers within the regional health authorities and the department, and they have a very important role of assisting the health system leaders in the CHRSP process. So within Western Health, we have 2 individuals assigned as CHRSP Champions. That's our VP of Quality and Research and our Director of Planning and Research. Their key role is to create awareness and market the CHRSP process within Western Health, as well as provide a linkage back with the Centre of Applied Health Research.
There are a lot of questions, a lot of issues that the system needs to resolve. How do we decide which ones to work on? We use a series of filtering criteria that are listed there. The first is importance. How urgent is it? How important is it for the healthcare system to know what the scientific evidence is on a certain question? What's really important, what isn't? We pick the important ones. And importance, you can see the sub-criteria listed under importance. Timeline. Urgent is good, but too urgent doesn't work. If they need to know tomorrow, we can't do it. If they need to know within a month, we can do it. Better still, if they can wait 6 months, we can do an even better job. And we've in fact developed techniques for answering questions in a month and answering questions in 6 to 7 months. It's 2 different styles of report. You'll see that in a minute. Feasibility. Is the question researchable? Is there research on it? Can you formulate the question in terms, in language that would be subject to scientific evidence? Some questions can be, some questions can't be. Availability of evidence. Is there good quality, systematic review literature? And then finally, can we find the experts to work for us on the project? Is the team available? So those are the filtering criteria. Now a little bit from Kelli about the process.
So within Western Health, in the fall of each year, Our CHRSP Champions solicit input on questions from our entire leadership team, and they're looking for pressing research needs or pressing questions that we need answered to make better decisions. The champions actually support our leadership team in helping to identify what makes a good question. So a topic may be presented or a question may be presented back to our champions, who will then, there'll be a bit of back and forth in terms of formulating the question and formulating the idea and teasing it out a little bit better. The champions then send the list of pressing questions or topics that they would receive from the leadership group to senior leadership, who then prioritize the topics for consideration. In terms of setting priorities, we provide our topics to the centre and through the CHRSP team, who meet with the health system leaders, and there's a priority setting process that is undertaken at that level in partnership with the 5 partners Stephen spoke about. Certainly the end result is that we end up with high priority topics that are studied in the evidence and context, if it's 6 to 7 months, or if it's more pressing, in the rapid evidence report. In terms of the prioritization setting process, the filtering process that Stephen spoke about earlier is actually undertaken with the CHRSP team from the centre and the health system leaders to actually set those priorities. So they're looking at the things of importance, timelines, feasibility, availability of evidence, and availability of a team. Putting all that around the topics and the questions, we come up with some priorities. We agree to some priorities as a health system with the centre.
And steps 1 and 2 involve really a surprising amount of back and forth between people at the centre and people in the health system. It's really quite unusual for that kind of interaction to happen. And partly it works because this is a small place with only 5 key units rather than 20 health regions, and everybody knows everybody. This process finishes up at a meeting of the 5 system leaders. We go to that meeting, they vote, they come up with their priorities, and we set a list of topics for the year. Step 3, once we've picked a topic, we do a topic by topic. For each topic, we build a team, we build a project team, and you can see the composition. It involves people from the research world, people from the policy world, people from the clinical world. Teams will have sometimes 8, sometimes 10, sometimes as many as 15 people. 15, which turns out is many too many. It's very hard to do that one. There are 2 key people. There's the team leader. We tend to contract out that role. We find a national or international leading expert on that topic, and we ask them to be the scientific leader of the process. If we can find somebody here, we will contract with them. The advantage is we don't have to pay them because they're already being paid by Newfoundland. But generally, we tend to go outside the province. We write up a contract with that person who serves as our expert. We also have 1 senior leader from the group of 5 as the system leader on the team, and then we put together the rest of the team. I sit on each project. We have staff from the CHRSP team on each project. We also tend to hire a health economist, because many times the question is not only would this work, but what's it going to cost? What's the relationship between the possible benefits and the costs? There's no point introducing something that would have lots of benefits, but an enormous cost. Step 4 is we find the evidence, we assess it for quality, and then we bring it together, analyze it, synthesize it, and come up with what are the key areas of agreement and disagreement. What does the literature say is important and not important? What does the scientific literature say is workable and not workable? And as I said before, we pay attention to reviews of studies. If you pay too much attention to individual studies, you can get sidetracked by an outlier. It's a brilliant looking study that says drug X works. Turns out that it doesn't, except in the small sample that researcher so-and-so studied. When you look at 10 different studies of drug X, it turns out that one person thinks it works and has scientific evidence that it works, and 9 people don't. So you pay attention to the 9. Then what we do, and this is the really interesting trick of this program, we contextualize it. The C in CHRSP is for contextualized. The crucial thing is both the question and the analysis of the findings have to be relevant to here. You have to pay attention, or we have to pay attention, to the local context, by which we mean a whole array of factors that make Newfoundland and Labrador, and sometimes rural Newfoundland, as distinct from even St. John's, if that's what we're focusing on, special. Because just because, as I said before, it works in New York City doesn't mean it's going to work here. Or even just because it's a problem in New York City doesn't mean it's a problem here. So we contextualize both the question and the research analysis and synthesis based on some of those factors: demographic factors, siting factors, characteristics of our health system, what we can afford and what we can't. Health human resources is often very important. Don't try to tell the system to introduce a program if you don't have the appropriate health human resources and can't afford it. So that's the contextualization step, step 5. Step 6 is to draw out not only what the findings are, but what they imply for decision making here. We started out thinking about this section of each of our reports as recommendations. And basically we were told to back off. It's the decision makers who make the decisions, and their advisors who make recommendations to them. We, the scientists, tell them what the evidence implies, what the evidence suggests. So we took a step back and said, here's what the evidence implies for you. Here are considerations that emerge from the evidence for health decision makers in Newfoundland and Labrador. Then we produce a report and have it reviewed by an external expert. It's always peer-reviewed by another senior, out of the province, national or international expert. And then we produce it in short, sharp reports, no more than 30 pages, which can be disseminated easily and which encourage system leaders to read the things and take them up and use them.
As Stephen said, there's 2 project types. The first is the evidence and context report, and this really is a full synthesis of the research evidence on one of those high priority topics that we've identified as health system leaders. The deliverable, as Stephen spoke to, is a 35 to 50 page full report, an executive summary, a 1-page layperson summary, and other multimedia products. They're really, really valuable dissemination means of the information from the project in terms of the multimedia.
We discovered about a year ago that our system leaders really liked the 6 to 7 month ones, but occasionally really needed to know what the evidence said fast. So we developed what I tend to call in private the quick and dirty approach. 30 business days from start to finish, a shorter report that summarizes the evidence, its strengths and weaknesses, the agreements and disagreements, and the factors that would need to be taken into consideration to contextualize it. It's 7 or 8 pages long, and we do it in 30 days. So depending on the urgency of the topic and the nature of the evidence, we either do a big one or a little one, a 6 or 7 month one or a 1 month one. Here is a list of the projects that we did between 2008, when we started working, and the current date. There are 12 of them. You can see that some of the topics are about technologies, a device, dialysis, what works, what doesn't. Some of them are about programs, policies, interventions. Some of them are about programs that deliver technologies. Some of them are about how to organize the health system better, how to organize care, how to treat seniors, for example, the third bullet point from the bottom, at home rather than bringing them into institutions. At the bottom, how nurses and nurse aides should lift patients. What works, what doesn't. Here are the topics that we're going to be working on, that we're currently working on this year. You can, I hope, see them. So that's what we're working on now. Some of them are really quite interesting, including the last one, the flu vaccination for healthcare workers. How do you get healthcare workers to vaccinate, to accept vaccination for flu so they don't pass it on to their patients? It's actually very tricky, and there are interesting ethical and contractual issues involved. So, the distinguishing features summarized by Kelli of our approach, of the CHRSP approach.
So certainly it focuses on specific urgent questions identified by the system. So in terms of relevance, that's certainly one of the distinguishing features. Uses both local and external expertise, and the team is built that uses both researchers and decision makers who are part of that team. The whole contextualizing of the factors of social, economic, health system, health human resources that Stephen spoke about. It is done fairly quickly, 6 to 7 month turnaround or the 30-day turnaround, and certainly we believe it communicates effectively the evidence.
Okay, so does it work? Well, for starters, it works better than anything we've tried before, and as far as I can tell, I go to a lot of conferences around the country. It works better than anything any other province has figured out, except maybe Manitoba, which introduced a system like this, although pretty different, about 7 or 8 years ago. The topic selection process is complicated. We've tried to simplify it, but as Kelly's nodding, it actually is quite tricky, particularly getting the 5 system leaders to actually agree on what the 4 or 5 hot topics for this year are. But that has worked. The contextualization process, which felt tricky to begin with, but which is obviously the crucial step, took some working out, but we now have a template that we apply with a series of questions for every study. You modify it study by study, but there's a set of questions that you ask. So we've got that down. We initially were very skeptical about our ability to get very busy external experts from across Canada or the States to act as the project leader, but that's worked out very nicely. The teams have worked together very well, and one of the things that I have found is that we have developed over the course of 5 years or so a much improved ability to talk to one another across that bridge or gap. We're much better at organizing questions so they make sense for the system, and the system people are now much better at picking topics. Before, it was really tricky. We would get either a laundry list of 40 topics, most of which weren't researchable, or dead silence. Now, the system is really good, and Western is really the best, which is why they're here, at developing questions that are important, researchable, and relevant to the context. And the most interesting thing is that the results have actually been used. This is the real kicker. Mainly, people do research, they publish it, nothing happens. Or you do research, you hand the report to a CEO or somebody at Kelly's level, and you know it's simply going on the shelf. These don't go on the shelf. People actually read them, and sometimes they actually do what we suggest they ought to do. Kelli, any comments on that?
Absolutely, Stephen. I can think certainly the dialysis decision template and the introduction of dialysis, the satellite unit in Port aux Basques. Certainly the report was used to make that decision. You list all kinds here. We've used it around the mental health mobile crisis teams, the rapid report that you've done, age-friendly acute care. We're in the middle of looking at that in terms of implications for us around a restorative care unit. So we absolutely do use them, and I think it's the whole relevance piece and the involvement piece from throughout the whole process that ensures that happens.
And this is really very unusual, to do research and then get the people who make the decisions to pay attention to it and actually show you signs that they are changing what they're doing because of the research that you gave them. And one of the keys, just to conclude, is this personal partnership with the 5 systems, their leaders, and their champions. The other key is the contextualization. When I hand Kelli a report, she has often already worked on it. She has been on the team, or somebody who works for her has been on the team. So this isn't a surprise to them. And they also know, Kelli, Vicky at Eastern, they know that it's been adapted for them. So they really do pay more attention to it than they would if it were just something that comes over the news saying a research report has indicated that drug X doesn't work. So it's the contextualization, and it's that tag team partnership that this program has worked out that actually makes this work.